So good afternoon, dear friends. Today we'll be talking about blood gas analysis and blood gas. So the basic purpose of this presentation is to tell you about the basics of blood gases, why we need to do blood gases, the normal values, how to read a blood gas, what should be the approach, and various common acid-base disorders which are seen in the neonates and common etiologies. Next slide, please. So as we all know that blood gas is the gold standard to know milli-interior of a neonate. We all know that the normal pH is between 7.35 to 7.45. So there is only a margin of 0.1. Any variation in pH on the either side can be detrimental and can lead to cell death and ultimately organ failure and death. Blood gas is important not only to know the inadequacy of oxygenation or ventilation, especially in a neonate. We know that even excess of carbon dioxide, that is hypercapnia or oxygen, they are even more harmful. So on change on either side can be harmful. Also, the neonates are prone to acid-base disorders. So we need to do these more frequent in this population. But there are certain caveats. The caveats is that the blood volume in a neonate is roughly around 250 ml for a term neonate, which can be even lesser in a preterm, very preterm baby, compared to adults who have a blood volume of 50 liters. So each time we stab them, we are almost consuming around 1% of their blood. Also the SS, getting an arterial SS in a neonate is very difficult because of the small caliber of the vessels. And also if these vessels, there is extravasation or there is blood loss, it can lead to death. Also, we know that there is rapid changing physiology and there are various shunts going in across the heart like PDA, which makes interpretation quite a tedious job. Next slide, please. Now, how is a neonate different from an adult? Neonatal period is a period of rapid growth and metabolism. Therefore, the production of H positive ions is 2 to 3 times higher compared to children and adults. On the other hand, they have immature buffer system, especially the renal system. Their concentrating ability is less as compared to children and adults. They have low buffer base, low bicarbonate, and they are prone to GI disturbance. That's why neonate is more prone to get acid-base disorders when we compare them to children and adults. Next slide, please. So this is the basic equation which governs an acid-base disorder. That is, bicarbonic acid can either dissociate to produce an H positive ion, which is an acid, and a bicarbonate ion, or it can go on the other side to form CO2 and water. CO2, we all know, is a volatile acid. It can be excreted with the help of the lungs through respiration. Bicarb can be excreted with the nervous system. So the two main systems which are involved in maintaining milieu interior are the kidneys, that is the renal system, and the respiratory system. Next slide, please. So what are the indications of doing a blood gas? Whenever there is inadequacy between the demand and the supply, as is commonly seen in shock, even before the clinical presentations, we can pick the disorder with the help of a blood gas. Or if there is inadequate delivery of oxygen to the tissues, as is seen in hypoxia, HI, blood gas is essential. Also, if the process is already set in, that is, if the baby is already deteriorating, he's on respiratory support, to know whether we are doing adequate management or not, whether it needs any change in the management, whether our treatment is working or not, blood gas is important. For a baby who's already on respiratory support, the goals of blood gas are to know what type of disorder the baby is having, what is the severity, magnitude, and whether there is any compensation or not, and whether we need titration of therapy or not. That is the most important. Next slide, please. So what is pH? pH is basically negative logarithmic scale. It is negative because the pH and the H positive ion, they go in opposite direction. If there are more H positive ions, pH will be low. Similarly, if pH is high, the H positive is low, and if pH is low, the H positive ions will be higher. Why it is represented in pH is because there is a wide variation in H positive ions. For each zero point 0.1 change in pH, that is between 7.35 to 7.45, there is 10 times change in the H positive ions. So to make the things simple, Anderson told simplified this classification and gave it a logarithmic scale, so that the pH should be represented in logarithmic scale to make it more simple and more easy to understand. That is why it is called negative logarithmic scale. Any variation from the normal physiological pH on either side, that is less than 7.35 or less than 7.45, leads to various complications, which we'll be discussing in the subsequent slides, and can lead to cell death. That is why it is of utmost importance to maintain the pH between 7.35 to 7.45. Next slide, please. Next slide.
Hello, Dr. Akash, we cannot hear you.
Yeah. Next slide, please.
No, I think your voice is.
Hello.
Yes, it's coming.
Next slide, please. So why do we need to maintain a normal pH? Each cell of the body needs a normal physiological pH because each enzyme, each cell system, to function optimally, they need a normal pH. If this function is not maintained, the cell process will come to fault. There will be cell death and ultimately leading to organ failure. If the pH is on the acidotic side, it is not only the lungs and the kidneys which are affected. We all know that if there is acidosis, there will be myocardial depression, there will be arrhythmias, and there will be hyperkalemia. And each one of these entities is a life-threatening complication. Similarly, if there is alkalosis, there again can be arrhythmias, there can be irritability, jitteriness, seizures, and hypokalemia. Again, endangering the life of an individual. Therefore, it is important to maintain pH between 7.35 to 7.45 to allow each cell and each cell function to its best capacity. Next. So for each problem, the nature has some defense system in place. For example, sepsis, acid-base disorder. We have various mechanisms to prevent any change in the pH, which is known as the buffer system. Broadly speaking, the buffer system can be divided into two types. That is the chemical buffer system and the physiological buffer system. The first and foremost defense system which comes into play when there is an acid and base disorder is the chemical buffer system. These are broadly of three types. 50% of the buffer activity is managed by the bicarbonate buffer system. The phosphate is followed by the phosphate and protein. The chemical buffer system is further divided into two types, that is extravascular and intravascular. Extravascular comprises of bicarbonate and the plasma proteins, whereas intracellular are usually governed by the phosphate, sulfate, and other body proteins. If these mechanisms fail, they are not able to maintain pH in near normal, then the physiological buffer systems come into place, which are mainly governed by the two organs, as we discussed, respiratory and renal mechanism. If the cause is respiratory, the kidneys will try to either excrete or retain bicarb. On the other hand, if kidneys are at problem, that is, there is problem with the metabolic respiratory, metabolic acidosis or metabolic alkalosis, the lungs will try to compensate. Next slide, please. So before knowing about the neonate, we should know something about the ABG machine. Normally, ABG machine calculates only three things, that is pH, PCO2 and PO2. Rest all other parameters are calculated from these three parameters using Sigard-Anderson nomogram. In some machine these days, they also have ability to calculate lactate and glucose. And some machines may also give you value of the methemoglobin. However, remember that each machine needs an input in the form of hemoglobin of the patient, the temperature of the sample, and the FiO2. The patient is on oxygen therapy. What is the FiO2 you are giving? These three parameters should always be fed to the machine in order to get correct results. Some of the newer machines, they can calculate hemoglobin. But again, you need to know about your machine, whether it is calculating or you need to feed. If you don't feed these three variables, the values may be inappropriate. Other thing which you should know about your machine is calibration. That is, the ABG machine has to be calibrated. The calibration is governed by the coefficient of variance, and there are set norms for each of these three parameters, primary parameters, which are measured by the machine. Next slide, please. So here you can see there is a set definition of the coefficient of variance. Now a simple test to know whether your machine is really calibrated or not. Next slide, please. Is the governed by the Henderson equation, where you can calculate the number of H positive ions by the formula 24 times PaCO2 by bicarb. Once you calculate this H positive ion, then next slide, please. You see whether whatever H positive ions you are getting, you see whether it is corresponding to the pH which is shown in the blood gas or not. If it is corresponding, that means the machine is calibrated. If it is not corresponding, that means you need to calibrate your machine. This is a simple bedside test which can tell you whether your machine is a calibrated one or it needs calibration. It is not exactly accurate, but it gives a fair estimation. Now moving on to the next slide, please. Now before knowing abnormal, you should know what are the normal values. The normal pH, as we have discussed, is between 7.35 to 7.45. CO2 is between 35 to 45. PO2 is between 50 to 70. Sometimes in tough cases, we can even accept up to 80 also. And bicarbonate is between 20 to 24. Base excess ranges from -5 to +5, and lactate should always be less than 2 millimoles per liter. Next. Next slide. So if the pH is less, we know it is acidosis. If the pH is more than normal, we know it is alkalosis. Similarly for CO2, if it is high, we know it is hypercapnia. If it is low, it's called hypocapnia. For oxygen, if it is low, we call it hypoxia. And if it is more, it is hyperoxia. These are the common nomenclatures. All these values are, however, derived from the adult population. Whether they are really applicable to neonates, we don't have any definite answer. As of now, we are continuing with these values even in neonates, but these are not from the neonatal population. These have been derived from the adults. Next slide, please. Now, there are certain precautions before doing a blood gas, before sampling, during sampling, and after sampling. Next slide, please. Next slide. So before doing the sampling, you need to choose the site. After doing all aseptic precautions and after doing the Allen's test, if you're doing a radial artery puncture, you need to carefully select the site. Now, the common sites which are available to us are either an arterial sample, either a capillary sample, or a venous sample. We all know that arterial puncture is the best. Now, whether it is a stab puncture is best or an inline puncture is best, it is always best that we have an inline catheter in place. Why? Because we don't need to puncture the sample. The problem with the arterial sample is, first of all, the SS. It is not easy to get an arterial SS in a unit because of the thin caliber, and we all need to maintain it. Even if there is loss of catheter from the artery, there can be torrential bleed, and sometimes it can lead to death also. Other thing is that arterial puncture is more painful compared to venous. It is because of the more nerve endings in the artery as compared to the venous. Now, the good point about venous sample is that it is easier to assess as compared to the artery. It is less painful. However, the values are not as accurate as arterial. Venous sample is good for bicarbonate and pH. However, venous sample should never be relied for oxygen. Now, the utility of venous sample is in patients who are on chronic ventilation but have a stable course. For example, patients with BPD. Usually, the pH of the venous sample is low, about 0.02 to 0.4 as compared to the artery, and PCO2 is nearly around 7 to 10 higher compared to the normal value. So if you get a, hello, am I audible? Hello.
Yes, we can hear you.
So the arterial sample is the best, but if artery is not possible, we can either choose capillary or venous. Capillary is in between the arterial and the venous sample, and this capillary sample can be derived by covering the periphery, that is the foot of the baby, with a warm soaked gauze for at least 5 minutes, and it gives a fair estimate of all the parameters. So if we don't have an arterial, first and foremost is the arterial inline. If we don't have arterial inline and the patient does not need repeated ABGs, we can do an arterial puncture. But if the patient needs repeated punctures, the capillary sample is the best. And if you are not able to do capillary because of various reasons, then the last resort is the venous. However, if the patient is chronically ventilated and his course is not downgoing, he is stable, you can also do venous sampling. Previous slide. Now, during the time of the sampling, the patient should always be calm. He should not be crying. If the patient is crying, that means he will have CO2 washout. And sometimes because of the crying, baby can go into apnea. So we will have a false low CO2 and oxygen also. So you should always calm your patient before doing the sample. And while taking the sample, you should always flush your syringe with the heparin, because we know that heparin is an acid. If you have more heparin, it will give a falsely low pH and more oxygen. Also, during sample processing, there should be no air bubble. The normal partial pressure of air, which is present in the air bubble, is around 150. So inadvertently, most of our babies' PO2 is less than 150. So they will have, the oxygen will move from higher concentration from air bubble into the blood, and it will go give you false high PO2 and low CO2. And if you are taking the sample from the line, you should always take 2 times the dead space. That is almost around 1 to 2 ml of the sample into the syringe, and then take the sample. Otherwise, you will get a diluted sample. And once you have taken the sample, those 2 ml should be returned to the circulation. It should not be discarded. Now, once you have taken the sample, the timing is of important, because blood is a living medium. If you will keep it pending, the RBCs will utilize oxygen and they will release CO2, leading to false low oxygen values and high CO2 values. Therefore, each sample should be processed within 15 minutes. If it is not possible, you have to send it to some other place, then it should be an iced sample. And you should always try to send the sample within 1 hour. Next slide. Next. So before interpreting ABG should be never interpreted alone. You should know the previous blood gases. You should know your baby. You should know the clinical status. You should have any X-ray which is done, and other investigation like sepsis screen and others should always be available. So it is a complete entity. Blood gas, you have to treat the baby, not the blood gas. Go with the clinical picture. That is always rewarding. Next. So few things about blood gas. Normally it has multiple panels. The upper panel shows the patient details. That is the patient name, CR number, name, and the date. Then the second panel, we have the temperature at which the sample was processed, followed by the common parameters which are commonly measured. That is pH, PCO2, PO2, and this is bicarbonate actual and standard. Standard bicarb gives you the actual metabolic component. Standard bicarb is the bicarbonate which will be present if the sample is taken at a PCO2 of 40 and temperature of 37. That is, it takes the component which is because of the CO2 and it gives you a pure metabolic component. Then the other panel is saturation, methemoglobin, barometric pressure of oxygen P50. Then we have electrolytes. Other important thing regarding these electrolytes in the blood gases, if your blood gas is not calibrated, do not rely for electrolytes on the blood gas. Also, your blood gas will tell you about the anion gap, which is important for metabolic acidosis. This we'll discuss in subsequent slides. Also, it will also tell you about the lactate and It will also tell you about the atmospheric pressure, which is sometimes important for calculating AaDO2. Or next slide, please.
You want to talk about these points?
Next slide. So blood gas, usually we need only 4 steps to read a blood gas. First and foremost is the pH. Now we know about the normal ranges, but for interpretation, for calculation, we take one value for each variable. For pH, we take it as a 7.4. So if the pH is less than 7.4, it is acidotic. If the pH is more than 7.4, it is alkalotic. So first step is look at the pH. If it is less than 7.4, it is acidosis. If it is more than 7.4, it is alkalosis. Now second step is, once we have labeled this, that this blood gas is showing acidosis or alkalosis, second thing is we need to know the reason. Is it metabolic or it is respiratory? If it is respiratory, second thing is we have to look at the CO2. We know that CO2 is a volatile acid. If there is an acidosis, so CO2 has to be increased. If CO2 is increased and there is acidosis, it is respiratory. If CO2 is normal or less, then move on to bicarb. Bicarb is in base. So if there is acidosis, the base should be decreased. So if there is acidosis and bicarb is decreased, we know that it is metabolic acidosis. So two steps. First is look at the pH, ascertain whether it is acidosis or alkalosis. And second thing is find out whether it is because of the respiratory component. That we'll come to know for looking at the PCO2. If PCO2 is normal and it is not explaining the change in the pH, look at the bicarb. Next slide, please. So for example, here we know that pH is 7.21. So this is less than 7.4. So this is an acidosis. Here the pH is 7.5. We know it is more than 7.4. So it is alkalosis. Next slide. So again, recapitulating the same point. If it is respiratory, the CO2 has to be abnormal and it has to explain the change in the pH. And if it is respiratory, it has to be PCO2, which has to be abnormal with normal bicarbonate, or there can be compensation. And if it is because of the metabolic component, the bicarb has to be abnormal and it should be able to explain the change in the pH. Next slide, please. So for example, here first step is to look at the pH. So pH we know it is less than 7.4. So it is acidosis. Now second step is to know whether it is respiratory or whether it is metabolic. Here we know that PCO2 is increased. So there is an increase in this acid. So increase in acid will produce acidosis. So increased PCO2 is able to explain this acidosis. So this is a respiratory acidosis. Had it been metabolic, the PCO2 would have been decreased, but here it is normal. So it is not able to explain. So this is a respiratory acidosis. On the other hand, if we look at this place, the pH is 7.5. That is, it is alkalotic. On the alkalotic side, on the higher side. PCO2 is 50. That is, this is an acid and it is increased. Now, this doesn't explain the alkalosis. So we move to the bicarb. Bicarb is in base and it is increased. So increased base is able to explain our alkalosis. So this is metabolic alkalosis. Next slide, please. Now again the same thing. Look at the pH. If it is low, it is acidosis or acidemia. Now what is the difference between acidemia and acidosis? Acidemia is if it is the pH in the blood. If it is less pH in the blood, it means acidemia. If it is more high pH in the blood, it means alkalemia. The process which causes these at the tissue level is known as the acidosis or alkalosis. Acidemia may not always lead to acidosis. Similarly, alkalemia may not always lead to alkalosis. The compensation can neutralize them and tissue may not bear any insult. Now, if there is acidosis and there is high PCO2, it is respiratory acidosis. If CO2 is normal, look at the bicarb. If bicarb is low, it is metabolic acidosis. If pH is high, it is alkalosis. And if it is because of the respiratory alkalosis, there has to be loss of CO2. That is, acid has to be low. So it is respiratory alkalosis. If PCO2 is normal or high, look at the bicarb. For explaining the alkalosis, the base has to increase. If there is high bicarb and there is alkalemia, it is because of the metabolic alkalosis. Next slide, please. So now the third thing is to tell whether there is compensation or not. Normally, as we discussed during buffer system, that body always tries to resist a change in the pH, but compensation is never complete. That is, it will never bring back pH to the normal. It will be near normal, but it will not be completely normal. So compensation can be two types. In majority practical purposes, it's always a partial compensation. If you see a complete compensation, you have to rule out mixed acid-base disorder. Next slide, please. Next slide. So compensation. So the compensation is either by respiratory or metabolic compensation, depending which is the primary system which is involved. If there is primary is metabolic, so there will be respiratory compensation. When we compare the two, the respiratory compensation is always the fastest. It is the most efficient. It starts within minutes and completes within 12 to 24 hours. That means if you have a metabolic acidosis, we'll have a rapid breathing. That is, the rate will increase, respiratory will increase, and will wash out CO2 within minutes. Similarly, if there is alkalosis, our respiratory will decrease and there will be CO2 retention. On the other hand, if there is respiratory acidosis or if there is respiratory alkalosis, the kidneys take some time to compensate. It usually takes hours, around 2 to 6 hours to start this compensation, and it usually takes days, around 2 to 5 days for this compensation to occur. So respiratory compensation occurs within minutes and is almost completed by 1 to 2 days, whereas metabolic compensation takes some time. It is not as efficient as respiratory compensation. And whenever the patient is on ventilator, we cannot talk about compensation because there the patient is not controlling his mechanisms. It is we, with the help of the ventilator, which are controlling his compensation. So compensation in real sense is for a patient who is breathing spontaneously. Next slide, please. Now, other easy thing to remember is that if PCO2 and bicarb, they go in same direction, it is a simple acid-base disorder. There are 4 types of simple acid-base disorder, that is metabolic acidosis alkalosis or respiratory acidosis alkalosis. In simple disorder, the both will be going in the same direction, as you can see here. Whereas if it is a mixed acid-base disorder, the CO2 and the bicarb, they will go in opposite direction. And the change in pH cannot be explained by either of these two. That is, the change in pH will be out of proportion to either change in CO2 or either change in the bicarbonate. Whereas in simple acid-base disorders, the change in the pH can be explained by either CO2 or bicarb, whichever is abnormal. So if there is complete compensation, always and always think about mixed acid-base disorder. Next slide, please. Next slide, please. Now to calculate the compensation, if it is metabolic acidosis, the expected PCO2 is governed by what is called as Winter's formula. That is, expected PCO2 is calculated as 1.5 times bicarb plus 8 plus minus 2. If your PCO2 falls in this range as calculated by the equation, that means there is compensation. Similarly, for respiratory acidosis, if it is acute, that is within 48 hours, the bicarbonate increases by 1 for each 10 mm change in CO2. And for chronic cases, it increases by 4. That is, bicarbonate increases by 4 for each 10 mm Hg change in the CO2. When we move to the other side, that is alkalosis. If it is metabolic alkalosis, again PCO2 here is governed by formula. That is, expected PCO2 is 0.9 times bicarbonate plus 9. And if it is respiratory alkalosis, again for each 10 mm change in CO2, for acute cases, bicarbonate will change by 2. And for chronic cases, the bicarbonate will change by 4. In neonatology, most common disorder is the metabolic acidosis, which we see. And we usually see acute disorders. Chronic disorders are rare in neonatology. Next slide, please. Next slide, please. So this is again another method which is used for calculating compensation. For each 10 mm change in PCO2, the pH changes by 0.08, and for each 10 mmHg change in bicarbonate, the pH changes by 0.16. That is double as compared to CO2. That is, any change in bicarbonate 10 brings a change of pH by 0.16, and any change in PCO2 by 10 brings a change in pH of 0.08. Next slide, please. So, for example, we see this patient one. Here, it's a 28-weeker day full of life with prolonged CRT. When we do a blood gas, the pH is 7.28, PCO2 is 30, and bicarbonate is 40, with PO2 of 60. Now, how to interpret this blood gas? So, step one would be see the pH, which is less than 7.4. So, it is an acidosis. Now, whether this acidosis is explained by CO2 or not, CO2 is a volatile acid. So, it should have increased, but here it is not increased. So, it is not respiratory acidosis. Now, we move on to the bicarb. Previous slide. So, now we move on to the bicarb. Here, bicarbonate is 14. This is bicarbonate is a base. So, for explaining acidosis, the base should be less. So, here the bicarbonate is decreased. So, this is a metabolic acidosis. Now, the fourth step is always look at the oxygen, which we never do. Next. Now, we see whether there is any compensation or not. We saw that pH is acidotic, PCO2 is not able to explain, bicarbonate is low, so it is a metabolic acidosis. Fourth step is whether it is compensation. I told you compensation is of two types, complete or partial. If had it been complete compensation, which is rare unless it is a mixed acid-base disorder, it would have been a normal pH, but it is not normal, so it is a partial compensation. Now we, by that master chart, we know that for each 10 mmHg fall in the bicarbonate, the pH should fall by 0.16. So normal for calculations, we take bicarbonate as 24. Although the range is between 20 to 24, but for calculations, we always take bicarbonate as 24. So normal is 24, and here our bicarbonate is 14. So it has fallen from 24 to 14. That is a change of 10. So how much change in pH it should have brought? That is, normal pH for calculation is 7.4 minus, that is for each 10 change in the bicarb, the expected change in the pH is 0.16. So the pH should have been 7.24, but pH is more than 7.24. So that the body is trying to bring it to near normal. So there is partial compensation. Again, by Winter's formula, we know that expected CO2 is 1.5 ton bicarbonate plus 8 plus minus 2, which comes out to be between 27 to 31. And our PCO2 lies in this range. So again, it is a compensation and it is a partial compensation. So it is a case of, now don't never complete your blood gas interpretation before looking at PO2. Here PO2 is between 50 to 70. So there is normoxemia. So to label this blood gas, we'll say that it is a metabolic acidosis with partial compensation with normoxemia. Never stop without commenting on oxygen, because it is not always hypoxia, but hyperoxia is also dangerous to neonates because of the free radical injury. Next slide, please. Again, this is again to re-emphasize the same fact that if the PCO2 changes by 10, the change in pH will be 0.08. So if the PCO2 is increased, pH should have fallen. So what will be the expected pH? 7.38 minus 7.08. It will be 7.30. Next. Again here, if we see this blood gas, the pH is 7.5. So it is alkalosis. PCO2 is normal, so it doesn't explain alkalosis. Bicarbonate is increased, so the base is increased and it explains the alkalosis. How much it has increased? It has increased to 34. So normal cutoff for calculation we take as 24. So it has increased by 10. So increase of 10 should have brought a change in pH of 0.16. So 7.4 plus 0.16 should have been 7.56. but it is less than that. So again, body is trying to bring it back to the normal. So it is metabolic alkalosis with partial compensation. Again, if you calculate it with the help of the formula, that is expected PCO2 in case of metabolic alkalosis is 0.9 times bicarbonate plus 9. It comes out to be 39.6 and you have exactly that value. So it is a metabolic alkalosis with partial compensation with normoxemia. Next slide, please. And same is in this slide. Next slide. Now, etiology, I have just tried to make few mnemonics so that you can easily remember. Remember, for respiratory acidosis, any respiratory disorder, whether in the parenchyma or pleura, pneumonia, RTS, muconium aspiration, effusion, air leaks, they can produce respiratory acidosis. If the baby is already on respiratory support, any displacement, obstruction of the tube because of the secretions, pulmonary edema, PDA can produce respiratory acidosis. Metabolic acidosis can be whenever there is mismatch between the demand and the supply, as occurs between shock, sepsis, or if there is hypothermia. Sometimes, if we give excess PWEP, either with the CPAP or ventilator, it repeats the venous return. Again, it can produce metabolic acidosis. Metabolic alkalosis can either be because of the loss of H positive ions with the help of which can be seen in vomiting, nasogastric aspiration, loss in stools, or through kidney, as can be seen in renal tubular acidosis, or if there is addition of base in the form of we are giving bicarbonate, it can cause metabolic alkalosis. Next slide. Now, for metabolic acidosis, one important entity is anion gap. Normally, there is an electrophysiological neutrality, that is cations, that is positive ions and negative ions, they are equal. But certain anions cannot be measured with the help of our tests, our biochemical processes. They are unmeasured ions. So normally, the left hand side, that is sodium and potassium, should have been equal to the right hand side. But it is not true because we are not able to measure some anions. So the difference, whatever comes between sodium plus potassium minus chloride plus bicarbonate, that is the anion gap. That is the reflectance of the unmeasured ions. Normally, metabolic acidosis is divided into two categories. Normal anion gap acidosis, which is seen in renal tubular acidosis or astazolamide if the baby is on astazolamide. Commonly in neonatology, we see increased anion gap acidosis, which is usually because of the shock, sepsis, acute kidney injury, or inborn measure of metabolism. The normal range lies between 8 to 12. Next slide, please. Now to tell whether it is a pure metabolic acidosis or there is an additional alkalosis, we need to calculate delta gap. Now what is this delta gap? Delta gap is calculated anion gap minus normal anion gap. Calculation purposes, we take normal anion gap as 10. Suppose our calculated anion gap comes as 20. So 20 minus 10 is 10. Now there is something called delta delta. This 10, we add the measured bicarbonate. If it is more than 26, so there is additional metabolic alkalosis. That is the utility of delta gap and delta delta. Next. This is only for if there is high anion gap metabolic acidosis. For normal anion gap metabolic acidosis, this is usually because of the either urinary loss of bicarbonate or GI loss of bicarbonate. How to tell whether it is urinary or GIT losses? We have to calculate urinary anion gap, which is calculated by urinary sodium plus urinary potassium minus urinary chloride. If it is positive, it is the renal cause. If it is negative, then it is the GI cause. Other thing which I have not covered is metabolic alkalosis. In metabolic alkalosis, we usually divide into two, whether it is chloride responsive or chloride resistant. If the urinary chloride is less than 10, it is chloride responsive. That is, the treatment flies on the volume replacement and potassium replacement. And if it is the urinary chloride is more than 10, it is chloride resistant. And it is usually because of the aldosterone excess. There the treatment is aldosterone antagonists like spironolactone. Sometimes we have to use indomethacin amiloride also. Next slide, please. Next. Next. Previous slide. So previous slide. Yeah, this one. So again, remember, never read ABG in isolation. Always serial ABG should be seen before making the diagnosis. Do a general physical examination of the baby, assess respiratory signs of respiratory distress, any X-ray if it has been done, take that into consideration, and then taking all these together, then take the therapeutic decision. Don't treat ABG, always treat the patient. Next slide. So the take-home message is that ABG is a simple tool to assess milieu interior. Remember, ABG is just a snapshot, but physiology, body process, they are a continuous process. ABG gives you a snapshot, so always take that into consideration. Always and always look at the baby first. No routine blood gases. Each blood during blood gas, it is painful. It causes blood loss. And remember, for doing blood gas, arterial sample is the best. Thank you. Next, these are some of the apps which are available both in the App Store. Previous complete ABG, ABG book, ABG analyzer, ABG interpretation made easy, which can tell you about the blood gases. If you don't have time to read or you don't know, this is the newer thing. Next slide. This is the newer thing which is there in the market. It's called an inline blood gas monitor. It is a closed system which gives a continuous, just like your saturation, it gives a continuous display of your blood gases that tell you about continuously what is the pH, what is the PCO2, what is the PO2, and here lies the future of the future ventilation. That is, we'll have inline and there will be continuous display of the blood gases. We don't need to stab and puncture. Thank you so much.
Thank you, Dr. Akash, for the wonderful presentation. We now open up the session for question and answers. Whoever has a question, please raise your hand or unmute yourself to speak.
Please unmute one by one.
We have a question from Dr. Rafiq. He asked about PO2. Is PO2 reliable in CPG?
Is PO2
reliable in CBG?
Ideally would be an arterial sample, but yes, if arterial sample is not there, then capillary sample is almost, you can take it as a marker. Again,